yet. Oh, there you go, right on cue. And Noah, are you scribing? All right. Looking forward to it, John. Go ahead and dig in.
Okay. All right. So for the first aliquot of information, so I'm just going to share the 77-year-old man. Chief concern is double vision. He was referred by an ophthalmologist who we saw yesterday to the emergency department, comes in today. We don't have their notes. The patient isn't really sure what what specifically they were worried about. And he's coming in here, and I'll close the first aliquot with that and let you share if you have any kind of approach to this chief concern or any think about what key history you would be looking to take in your next pass.
Sure. Steph, I can maybe start the first one. And I'll start by saying that the pathway of an ophthalmologist referring someone with seemingly an eye symptom away from an eye doctor is appropriate here. Because diplopia, double vision, as opposed to diminished visual acuity, as opposed to a red eye, as opposed to eye pain, as opposed to floaters or other visual symptoms, obscurations, scotomas, etc., is fundamentally not an eyeball problem, but is instead an eyeball alignment problem. And all of us right now, looking at our screens, if we were to like cross our eyes a little bit, back and forth and cross and uncross, cross and uncross, we would have diplopia induced by intentional misalignment of our eyes, right? Double vision is almost always a problem with extraocular sort of motility and alignment, and which is very often a neurologic rather than ophthalmologic problem, or maybe an orbital problem rather than an eyeball problem. So that is why this referral is appropriate. And I think, as always, in terms of the question, John, of what information we'd be looking for, the time course is critical, right? Of how long this has been going on, whether it's intermittent or sustained or progressive, and then in parallel with the history that we're taking, the exam in this case is concurrent, right? You're looking at the patient's eyes, trying to notice, the conjugate, disconjugate gaze, esotropias, droopy lids, like a lot of, or other neurologic features in the head and neck that could give a clue as to what's going on. So, just to quickly summarize, double vision diplopia is a problem with eye alignment. And thus probably not an ophthalmology problem, but a neurology or general medicine or ENT even problem. And then in the history, time course always is extremely important. And otherwise, I would just be looking for kind of what other information in the story the patient would volunteer. And then finally, the exam kind of starts in parallel while you're having the conversation.
Right on, great discussion. So I think for the next aliquot, I'm just going to share the HPI and the histories. So I have a 77-year-old man. He presents with it's double vision in both of his eyes, time course tempo of about 10 days. And his wife also noticed some right-sided, some facial droop. And his double vision resolves when he closes either one of his eyes. Yeah, it's both kind of both a vertical and a horizontal component to it. The images are kind of diagonal from each other. There's no eye pain, there's no redness, there's no loss of vision. He's not sharing any other neurological symptoms. He's not having headaches. The other key, part of the HPI is 2 weeks prior to presentation, he had a febrile illness he had headache, fatigue, myalgias, no respiratory symptoms along with that. That part of things have improved, like that, that symptoms is resolved. There's no rash, no systemic symptoms. just give some time for this, make sure the scribe has everything here. So for the bottom left corner, histories, past medical history of hypertension, benign prostate hypertrophy. He had a remote traumatic brain injury to the right temple in his 20s. He had apparently had a cranial evacuation, but doesn't have any residual deficits from that. He has type 2 diabetes that's been well controlled, and he's got his A1C down into the impaired glucose tolerance range, and anxiety. There's no pertinent family or surgical history of note. His medications, he's on lisinopril, escitalopram, and takes over-the-counter vitamin. Social history, there's no tobacco, no alcohol, no drug use. Lives at home with his wife. So independent with his ADLs. No particular work-related exposures. Good functional status. He likes to go on walks with his wife and go hiking. And leave it the first, and close up the second aliquot with that. And let you turn the reins over to kind of share what are your thoughts and how are you making progress?
Thanks, John. Great history, and can tell it's going to be a great case where we learn a lot. Really helpful information in the story itself. There was a lot of discussion in the chat about when sorting out double vision, really defining whether it's a problem with one eye seeing double or both of the eyes because of the misalignment framework that Zaven went through. And the fact that it goes away when he closes one of his eyes indicates that, yeah, it's the two of them not working together as opposed to one of the eyes being problematic. So we know we're in the category of binocular diplopia. Which kind of getting into what can do that, my sort of framework is really simple. It's either the muscles that move the eye are weak, or there's like something in there, a mass or something compressing the eye such that even if the muscles are totally fine, the movements are obscured. So we don't really know based on the history yet if this is sort of a syndrome of weakness or compression, although often with orbital masses, there are outward signs or symptoms that there's something in there with proptosis, patients noticing one eye getting chemotic or bulging out. But seems like it's probably going to be weakness because another cranial nerve seems to be weak, and that is cranial nerve 7 with the facial droop. We'll see in an exam kind of whether this is a full lower motor neuron or whether it spares the forehead. But I think right now, knowing that some of the cranial nerves controlling the eye muscles are weak, as well as the facial muscles are weak, might make us sort of open the pathway to conditions that can cause multiple cranial neuropathies. With that, I think when we think about weakness in general, we often take an approach from CNS out to peripheral. And I think that's appropriate here. We don't yet have a physical exam to know what other signs and symptoms are there. But if these are this gentleman's only symptoms at all, I think we need to think about where these cranial nerves start in the brainstem, and the muscles controlling the eyes are in the upper part of the brainstem, and the cranial nerve 7 for the facial nerve is in the pons. But from where those originate in their nuclei to where they exit through the meningeal surface out of the brainstem itself, that is an area where any inflammation can cause at the exit of the nerve from the brainstem and the meningeal space a process. And then, of course, the peripheral nerves themselves can be affected, then down to the neuromuscular junctions of these nerves themselves. So my framework is that it seems like this might be weakness of kind of cranial nerves, and we'll have to sort of anatomically, like I said, work our way out from the brainstem nuclei through the meninges, down the nerves to the neuromuscular junction. But how the subacute kind of or the illness a couple weeks ago plays into it, not totally sure yet. Sounds like it was sort of a viral syndrome, which, right, a lot of us get all the time. But what complications can you have with viral syndromes, upper respiratory infections? You can with actual overt sinusitis, which doesn't quite seem to fit with his presentation get actual thromboses in the dural sinuses. I can't think of how that could explain the weakness of the face, but that certainly can cause paralysis of the extraocular muscles. Certainly being systemically ill or fatigued is often a pathway for other kind of autoimmune mediated neuropathies to happen, like Guillain-Barré syndrome, right, is often preceded by a viral illness, and there are variants that have kind of cranial nerve involvement early on. So what sort of inflammatory or infectious trigger from 2 weeks ago played out into the pathology of the cranial nerves? I think we'll have to figure that out. Zaven, do you want to layer on any thoughts from his medical history, just in terms of localizing a little more where this process could be based on his past conditions?
Yeah, I don't see a whole lot that's super helpful. I will just, I guess I just say that, you know, with the history, we've kind of generated some hypotheses of where the problem is, but I think the exam needs to firm that up of actually determining, you know, was this a full facial droop, and cranial nerve 7 is indeed involved, and then which of the extraocular movements are impaired, and thus which cranial nerve is involved. So yeah, if it's a lateral gaze palsy and it's, you know, it's cranial nerve 6 and 7, sure, that those triangulate to the pons, right? But if it's actually a third nerve palsy, and in fact it's just the eyelid that's a little droopy, you know, but not the whole face, maybe that's not actually a cranial nerve 7 thing at all. So I think just in terms of making a more specific problem representation, the neuro exam will be, as well as to see if there's any lesions anywhere else in the neuroaxis, right? So I think the exam will be really important. The only thing in the history that stands out is, you know, hypertension, diabetes, and other you know, vascular risk factors are risk factors for ischemic kind of nerve infarctions as a mechanism of cranial neuropathies, but that usually happens only one nerve at a time. So if there's really multiple cranial neuropathies, I don't think that would be as plausible of a mechanism.
John, would love to hear more. Oh, I think you're still muted.
Thanks. Yeah, great discussion. So I'm gonna, for the next aliquot, I'm gonna share the exam and just kind of the first pass labs and first pass imaging that obtained in the emergency department. So blood pressure is 108/72. Temperature is 36.9 or 98.4 Fahrenheit. Heart rate's 95. Respiratory rate is 18. And saturation's 94% on room air. So his general exam, he's no acute distress, well-nourished appearing. And, you know, cardiovascular is regular rate and rhythm. There's no JVD or pitting edema. His lungs are clear. Abdomen is non-distended with normal bowel sounds, no appreciable masses. And neuro exam, where the kind of meat of the exam here is. So note that his right pupil is sluggishly reactive when you shine a flashlight into it compared to the left. He has some slight ptosis of his right eye, and his right eye, he is like completely unable to abduct, and he has some diminished ophthalmoplegia. He has some difficulty with moving it up and down, but he has some motion, but not normal range. So he also does have right, you know, the facial, kind of a subtle like right facial droop. It's involving his upper and his lower face. Otherwise, his strength is fully intact. There's no sensory deficits. There's normal reflexes, normal gait. No other, you know, deficits that we picked out other than what we presented forward there. The basic labs, he's got a white blood cell count of 15.86, which was neutrophil predominant. Rest of the CBC unremarkable. His chemistries, his sodium is 124. Normal bicarb is 24. His creatinine is 0.72. Glucose 118. The LFTs are all normal. Got a chest X-ray in his first pass. That was, you know, no acute intracranial path. Sorry, no nothing nothing abnormal in the chest on the X-ray. And in the first pass, I saw some pop-ups. I think people considering, whenever you have new neurological deficits, always like the first thing you're doing is getting a CT of the head and CT angiogram of the head and neck. So it just showed this like chronic encephalomalacia in the region where he had that prior traumatic brain injury, but otherwise nothing acute. And there's no large vessel occlusion on the CT angiogram head and neck. So that was a lot of information. So also kind of potentially a good point in the case to try to summarize, and if you have kind of a summary statement to try to put it all together. What's signal? What's noise? How are you defining the problem, and next steps you might be taking to make progress?
Thanks, John. This case is definitely fascinating and challenging, and I guess just in the spirit of active learning, I would love to give everyone else, and quite frankly, I need it too, the time to just process the exam in the context of everything else we have. And I'd love as many people as possible to share their kind of problem representation. So y'all sort of think about it, start typing it up, and then when I say go, everybody can kind of enter it in the chat. No worries if you don't want to, but I think it'll be good learning if you want to put it forward. So hold off. Don't enter it yet, but prepare it. And when I say go. Okay. 1, 2, 3, go. I love this, and I actually wanted to see a lot of variability just to kind of show the spectrum of details, as well as how ready people differentially are to kind of jump to likely diagnoses versus not. But yeah, I think the key features, I do think it's worth mentioning the vascular risk factors, sure. I think it's worth mentioning the viral illness, like it just, the timing seems very notable. And then I love the representation of multiple cranial neuropathies. I also really do think it's helpful to maybe name which ones, just because they can potentially localize to a single anatomic or vascular territory, right? Or be affected in a more scattered, haphazard, kind of chaotic way, as would happen with inflammatory or demyelinating diseases. So which ones are involved? So there's cranial nerve 7. It does seem like there's an actual facial weakness, upper and lower, right? Keep in mind, whereas we normally associate upper facial weakness with a more peripheral lesion, in the setting of an acute central insult, you can have upper weakness too. It takes time for the bilateral innervation to kind of fully manifest and bring that strength back. And this does seem like a somewhat acute presentation. The right eye cannot abduct at all. That is indeed cranial nerve 6. And then the other difficulty with moving the eye up and down. So it's LR6 SO4, right? That's the mnemonic I learned. The lateral rectus, which abducts, that's the 6th nerve, and then the superior oblique, which is the 4th nerve. All other extraocular muscles are innervated by cranial nerve 3, so it does seem like that 3 is also involved. I'm curious what people make of the pupil, and just to clarify this, John, it's the right pupil that you're saying is abnormal, where in response to light shown into either eye, the right pupil is slower to constrict than the left. Is that correct?
Yeah, so like I'm just trying to like think back to the memory, but like the light shined in the right eye, then it was like it was a slow response. And if I remember correctly, there was also like a kind of the light goes in the right eye, that there's some such response. Kind of you always you see constriction bilaterally. Um, so it seemed you shined light in the right eye, and there was sluggish response, but kind of bilaterally compared to
Interesting.
when you
Okay.
shine light into the left.
So what I'm hearing might almost be actually an afferent pupillary defect. So let's just review the pupillary reflex arc real quick, okay? So if you shine a light into my right eye, that'll go through my right optic nerve, and then it'll actually that's the afferent arc of the reflex. And then there will be a bilateral transfer of that signal to where the efferent arc of that reflex will result in bilateral constriction equally of both pupils. And then if I take the light away, the pupils will dilate again, right? And then if I go and shine the same light into the left eye, the left optic nerve, cranial nerve 2, will transmit that signal in, and then both eyes again will constrict equally, innervated by cranial nerve 3 to respond to that light. So if I have an afferent problem, if it's a cranial nerve 2 problem because of optic neuritis or a tumor pressing on the optic nerve, or a big part of my retina having been knocked out, then if I shine the light into the affected side, the pupils won't respond as much because there's not as much signal going in. But then if I shine the light into the good eye, both pupils will have a robust pupillary response. So even though the optic nerve on the right is sick, the cranial nerve 3 and the pupillary constriction, the parasympathetic, that arc is actually intact. So there will be a full pupillary and brisk pupillary response if the light is shown into the other eye. So just to clarify, John, does it seem to be an afferent problem where if the light is shown into the right eye, there's less constriction? Or is it that whether light is shown into the left or right eye, the right pupil is slower to constrict and doesn't constrict as much as the left? If you remember,
Yeah,
and it's
so
okay if you don't.
yeah, so just like looking back live, I was having trouble remembering on the spot there, but I was like pulling up the neuro consult, and that was a case from some years ago. So
Okay.
some of the details were fuzzy, but it looks like this appears to be more of an efferent problem. Like the right pupil itself was more sluggish to react when the light was shown in either eye. So I apologize for the mix up in the previous response. So
No worries.
did not appreciate an afferent pupillary defect.
Okay, cool. And that actually, thanks so much for pulling that up and clarifying, because that actually fits a lot more with the presentation of cranial nerve, including cranial nerve 3 neuropathies, because the parasympathetic fibers that do the pupillary constriction are on the outside of cranial nerve 3. So it does seem like there's a right-sided cranial nerve 7, 6, and 3 process. And I actually am having trouble localizing those anatomically. So just like some people were thinking in the chat, I do wonder whether there might be a more kind of systemic, potentially demyelinating or inflammatory process that is affecting all 3 of those nerves at the same time. Steph, help me out.
I guess just there was some discussion in the chat about are the labs kind of helpful at all in this? My short answer is not really. The leukocytosis might speak to a systemic inflammatory process driving this, and does that actually relate to and continue from the recent viral illness? And the hyponatremia is, well, we'd have to figure out what it's from. We're getting a sense based on his volume exam and history. This should be someone who's euvolemic. So figuring out whether there is in the background an endocrinopathy versus inappropriate ADH. And if there is, what sort of the trigger is for that. And a lot of different things, right? Including kind of CNS pathology, which we don't seem to have for in the exam here, can drive it. So I think, to me, working up the hyponatremia as sort of its own separate problem list that I think in the end will relate, but I'm having trouble actually figuring out how they link now. And certainly don't think the hyponatremia explains any of this, right? The neurologic symptoms that you get from hyponatremia are essentially the symptoms of like brain swelling, right? Having a waterlogged brain. So feeling a little nauseous or vomiting, being a bit confused, not local neuropathies like this. So they're probably related, but not directly. I guess we're ready for some more info, John, to take it forward.
All right. So for the next steps, so we ordered MRI of the brain and the orbits with and without contrast, and just ordered that as stat to try to get it done quickly. So what this showed was abnormal enhancement of cranial nerves 3, 5, 6, and 7, and just enhancement of the cavernous sinus itself. And also, just like got some urine studies. Like urine, the serum osmolality was low. I don't have the exact number, but the urine osmolality was 400. Urine sodium was in the 60s, and around the same time we're getting the MRI. So the patient went into new atrial fibrillation with rapid ventricular response, and we got a 12 lead EKG. And this actually shows new ST elevations in leads V1 and V2, this kind of funny curved appearance at the top of the ST segments, in atrial fibrillation. And at the same time, we got a high sensitivity troponin is 14, and then a repeat a couple hours later was 10. I'll drop it there.
Case took a bit of a twist down from the head into the chest now. I am not certain, and Zaven, help me out with this. I'm just thinking about how does the MRI help us push things forward diagnostically? We had by exam worried about cranial neuropathies of 3, 6, and 7. Cranial nerve 5 is the trigeminal nerve. It's sensation of the face and then strength to the muscles. And at least it seemed like so far we hadn't picked up any signs or symptoms of that involvement, but we are seeing that there is inflammation of multiple cranial nerves. What I'm not certain about, well, I guess I should say it is helpful because we talked about that sort of anatomic course. It seems like it is the nerves, the kind of peripheral neuropathy themselves. It doesn't seem right like there's some anatomically perfectly placed brainstem lesion. Seems like that kind of meningeal space exiting out into the periphery is normal. So we're really looking at a problem of the nerves. The enhancement of the cavernous sinus. Now I know this isn't an MR venogram, so whether that puts on the table problems with sort of venous flow, I don't know. That's what I was going to kind of tag you in for, Zaven, on. Does that enhancement sort of mean anything to you? Because I'm just not sure.
I'm not either. Yeah, I think this is where I would want to talk to the neuroradiologist to see what that might represent. So, some of those, so the course of some of those cranial nerves goes through the cavernous sinus, right? But that's only 3, 6, and then the V1 branch of 5, right? So not the other branches of 5 and not 7. But I guess my so cavernous sinus thrombosis doesn't necessarily explain a facial droop, but here would be my question to the neuroradiologist. The 3, 5, and 6 seem to be involved, and they do go through the cavernous sinus. So if this was an infectious cranial neuropathy with Lyme or syphilis or whatever, or if this was an inflammatory cranial neuropathy demyelinating in a setting of Miller-Fisher syndrome, whatever, GBS variant, could it be that it's actually the nerves themselves in the cavernous sinus that are enhancing, and it's not a cavernous sinus problem. It's just the fact that the inflamed thing, which is the nerves, is tracking through the cavernous sinus. So that would be my hypothesis that I would want to test with the radiologist. Otherwise, I think the MRI just kind of confirmed what we suspected clinically and ruled out other involvements. But I'm just more intrigued by kind of some of these cardiovascular evolutions. Did you want to
I guess I'll give a few thoughts. If there was any question of this guy just being like systemically sick, right? He walked to the eye doctors because he had double vision. We know for sure he is now, right? The white count was a sign. The hyponatremia with the inappropriately concentrated urine suggests that ADH is on without a clear stimulus, it seems. So having inappropriate ADH excretion, having leukocytosis, and now having new onset rapid AFib, something is driving this, right? This really is a systemic process that's making this guy very inflamed and sick. The septal ST elevation seen on the ECG, presumably, John, this is when his rates were going fast.
Yeah, that's correct.
It's just a good reminder of a lot of stuff, because it seems like with his troponin elevation, right? He hasn't infarcted a significant part of his heart. So what can cause new focal ST elevations that isn't an occlusive thrombus? And the list is long, actually. It includes things like stress-related cardiomyopathies. You can have electrolyte disarray that does it, pulmonary emboli. And so what is actually driving kind of these changes that isn't actual plaque rupture and infarct will be an important thing to sort out. But I'll pass it to you, Zaven, for other ways to think about the ECG in particular.
I know we can't see it, John, you said, and that's okay. It would be helpful, right, to see exactly the extent, the contour, whether there's abnormalities elsewhere. But because in some patients, with either LVH or with early repolarization, like some degree of ST elevation in V1, V2 can actually just be physiologic too. And that, the clinical context matters a lot. I mean, in this case, yes, the patient went into AFib with RVR, but it sounds like they weren't really having chest discomfort, and importantly, the troponin sort of ruled out any significant myocardial injury that you would expect either with a vascular event, but also with myocarditis, which was kind of in my differential, just with kind of line being out in the ether with but the other explanation of both of the AFib as well as just the other systemic signature you were describing, Steph, is whether there's significant autonomic activation, which I think there can be with some of these demyelinating syndromes. There can be, again, dysautonomia, which sometimes takes the form of, hypofunction, and which other times can manifest as overactivity. We're not necessarily seeing that in the vital signs, right, in terms of tachycardia and hypertension, but just another potential kind of mechanistic explanation of this evolution. Ultimately, I think just to step back, and I don't know if I saw at some point somebody was like saying it would be good to have an updated PR. I don't know if anybody did offer one or would offer one, but I think just zooming out and considering this kind of like systemic febrile, specifically illness that almost immediately preceded the onset of multiple cranial neuropathies, kind of scattered a little bit in space, as well as systemic effects, including leukocytosis, hyponatremia, a new onset atrial fibrillation. I do think we're probably in the infectious and inflammatory world, and we've kind of named some of the specific conditions we would that could potentially tie things together. I think the challenge here is just to think about like specific next steps, right? Because I'd love to hear the next aliquot, but I'm trying to just challenge myself to just pause and be like, okay, if this is where I was in real life taking care of a patient like that, what would I do next So what do you think, Steph? And let me just catch up with the chat too, while we both think about next steps.
Yeah, so I think specifically diagnoses that can cause isolated kind of, or sets of cranial neuropathies. Things that I would wonder about and tests that would be associated with it. We've talked about all of the cranial neuropathies other than the cranial nerve 7 facial droop. Could be problems related to cavernous sinus thrombosis. So I would talk to a radiologist and see, based on that nonspecific inflammation seen on the MRI, is there a role for dedicated kind of MRI venogram to see if a thrombotic process in the venous system of the brain is at play. I think sarcoidosis is a multi-system inflammatory condition that can cause neuropathies. Cranial nerve 7 is one of the most common ones. Certainly can affect the heart muscle. And so I would sort of push a little bit more on sort of family history and look closer at the ECG, get an echo to see if there's anything that could suggest sort of an infiltrative process in the heart based on just those external parameters. Whether kind of, mononeuritis multiplex related to systemic inflammation from a vasculitis, et cetera, would be something that I would want to think about as well. With just these cranial neuropathies, we've brought up kind of demyelinating processes onto the table. There's a lot of variations, of course, of Guillain-Barré syndrome, and some of them do involve the cranial nerves, but I'll just say with some of the kind of sensory absence right now, I'm not sure it fits as well, but a way we could test that is to look at consider a lumbar puncture to get a sense of kind of protein and cell count in there. So kind of diagnostics are discussion with radiology, role of MR venogram, a better look at the heart with an echo to see, are we seeing any process there that could suggest also an inflammatory or infiltrative process of the nerves. And I think also thinking about whether a lumbar puncture could help us get in the right direction for the neuropathies. Can you add to that, Zaven?
Not by myself, but I was just catching up on the chat and saw Sridhara's sort of next set of testing from a few minutes ago, and one thing that's definitely indicated is an HIV test that they listed. But I think the possibility of a demyelinating disorder in this context is high enough that I think it is worth pursuing the LP, but also with the realization that I think even if there's cranial nerve inflammation, and you could and the cranial nerves do course through and have contact with the CSF. So if you do find an abnormal CSF, that's not diagnostic of Guillain-Barré, right? And specifically the pattern there is going to be important. So if this is Lyme or HIV kind of causing cranial neuritis and a degree of potential sort of meningoencephalitis in the CSF, you would expect both protein as well as cells, right? Whereas the sort of the key feature of what we call albuminocytologic dissociation is that there's proteins, presumed antibodies, but not necessarily a cellular inflammation, although a few cells can be present in GBS and its variants as well. So and then the easy thing, like, remember, Steph, like you have that picture that I always sort of visualize, like, but we used to see Lyme in that part of the country, and people sometimes would come in with a neurologic presentation, sometimes they would come in with carditis, sometimes they would come in with both, or joint pains or something, a febrile illness, and invariably a lot of these patients had a big old target or a big patch, somewhere on their back or knee or back of the knee or thigh or all of the above with sort of multiple lesions. So I think doing a really close skin exam here could really almost like obviate everything else we've talked about and be like, this is Lyme, ceftriaxone, next. So I think that's an easy one that would be good to, and it wouldn't rule it out, but it could potentially rule it in.
Okay, cool. Ready for the next steps?
Mm-hmm.
Okay, yeah, so I'll share some context. I like all the talk about like talking to the neuroradiologist and the importance of that. I'll share like they, even in their read of the study, they like shared a thoughtful differential diagnosis that borderline would have spoiled the case if I put it up on the screen. And throughout all these like cardiac things, when he went into the, he had the arrhythmia, his EKG, he was totally asymptomatic through all this. He's just like, why is everyone freaking out? What's going on? And so some of our next steps is we gave him a good head to toe look down. They couldn't find a rash anywhere. We got some cardiac workup, and some of the additional infectious workup kind of came back in tandem. But I'll start off by sharing some of the first pass before the final diagnosis. We checked a viral panel, including like COVID, flu, RSV, and other seasonal respiratory viruses. That was negative. A serum like VDRL and syphilis, EIA are negative, and HIV testing was negative. And we got a CT scan angiography of the coronaries, which showed some relatively mild coronary disease, but nothing occlusive. And we also got echocardiogram, showed normal LV-RV function, so normal echo. And also, I can kind of break there. The next bit of information will reveal the diagnosis from serum test and the lumbar puncture. But you want to digest the cardiac workup before I drop the diagnosis?
Yeah, thanks, John. I was basically cardiac workup being mostly normal, structural normal heart and minimal coronary artery disease, it sounds like. I've been thinking a little bit during this discussion about kind of what my illness script for Lyme carditis is, and we'll see if it evolves with this. But as far as I understand, it can cause a myopericarditis. Myocarditis, right, hadn't seemed to fit thus far with the normal troponins and the lack of kind of apparent myocardial injury on that test. And then heart block, right, actual a block. So I'll say it hadn't sort of been a explanatory model for his rapid AFib, as well as kind of the localized ST elevations without myocardial injury, but it could possibly be. So I think that'll be an important kind of factor for it. Zaven, were there other things that you're thinking we're getting closer to?
No, I mean, I think Lyme is still on a differential, and if I think that's one of the highest things, and the other one again just being a cranial nerve kind of centered GBS variant, Miller-Fisher syndrome, in which case the LP obviously helps with that, and then the serum test that John is alluding to could be one of the autoantibodies most associated with Miller-Fisher GQ1B. Thank you. So I think in real life, I feel like you might want to be doing those things in parallel and kind of weighing in a probabilistic manner the fraction of sort of probability attributed to each of the top differentials, and then thinking about whether empiric therapy is warranted and is worth the downside. So, for example, if this is Lyme, even if there's a 20% chance of that, I feel like the benefits potentially conferred of empiric doxycycline, if not just ceftriaxone, would far outweigh the risks, even though the benefits are diluted by the proportional sort of less than 100% probability of the disease existing. I think in the case of empirically giving starting IVIG, the calculus is a little different. The actual medical risks are like probably it's a safe intervention overall, but it's probably slightly higher than just for antibiotics in terms of the hypercoagulability, potential for renal injury, but there's the X factor that IVIG costs tens of thousands of dollars. So you don't want to just throw it around for nothing. But again, in terms of conferring benefit with early treatment, even if we only have 20 or 50 or 60% certain degree of certainty that this is GBS might actually be worth it. So I think this is where I would consult with expert specialists to help weigh those diagnostic probabilities and the analysis of potential therapeutic benefit with treatment before definitive diagnosis. And get an LP. Yeah.
Right. So asking you shall receive. So you got a lumbar puncture, and it shows a white blood cell count of 12, 79% lymphs. Glucose is 57. The protein is it was low. It was normal. Like the notes, it was kind of scratchy here, but normal protein. An infectious meningoencephalitis panel was negative. The CSF VDRL, like cryptoantigen, are negative, and so it ends up the Lyme antibody from the serum comes back positive at at a titer of 4.74, and as well as the Lyme from the CSF comes back positive, with confirmatory Western blot testing from both the serum and the CSF coming back positive. So kind of share how this, we did, the patient was treated with IV ceftriaxone and placed on a fluid restriction. The hyponatremia gradually improved over the days. And we're putting this together. It's like this. So Lyme in my area is a pretty common diagnosis, just with multiple like atypical factors of the presentation here. This is like not the normal like cardiac manifestations of Lyme. And with these ST elevations, we consulted cardiology and got this ischemic workup. And their thoughts were they thought this looked like a Brugada like type 2 pattern. And this could have been unmasked by just this like subacute inflammatory illness. And Brugada syndrome is like most classically associated with ventricular arrhythmias, but if you look, there is some association with atrial arrhythmias as well. So just this underlying inflammation unmasked the Brugada syndrome, is increasing his risk for AFib. And this may not have been his first time knowing about it, but he was asymptomatic through it. He may have had undiagnosed paroxysmal atrial fibrillation in the backdrop, and he's in the hospital on a monitor and inflamed. And so there's anything else like it's like the neuroborreliosis being associated with SIADH is also kind of uncommon, but any kind of intracranial pathology really can be a driver for increased ADH. So Lyme disease with CNS involvement causing SIADH and unmasking an underlying Brugada syndrome and atrial arrhythmias. Well, like he followed up after the completing the antibiotics, saw this symptoms completely resolved, and he is still doing well.
Awesome case. Thank you so much, John.
So cool. I've just been like looking back, and so fact check me on kind of this thinking, John. So the febrile episode 2 weeks before was his manifestation probably of early localized disease, whether he had erythema migrans lesion or not. Maybe he didn't see it, but it's also a good reminder. You don't have to have that. I think it's like 75% do, but a quarter of people don't. And then the time course of then 2 weeks progressing to the CNS and cardiac involvement, it fits. Sometimes it can take months, but like weeks is enough time to manifest into the neuro and cardiac. And in the end, that like he has a lymphocytic pleocytosis. Like it really was kind of the frank CNS involvement with, again, very classically, right? Bell's palsy from Lyme is something we think about, but I think in this case, having also the other neuropathies was just an kind of interesting twist to expand the neurologic footprint of this condition. Really, really cool case.
Yeah, that's kind of like the line of thinking. Like we're like they probably he may or may not have had an underlying rash that just was not picked up. Could have been somewhere he didn't notice. So that was what part of why the diagnosis was wasn't as straightforward. He didn't have a known insect exposure. He didn't have a known rash, but you don't have to. And Lyme is very common, especially it was if I told you that it was like the time of year and some of these things that might have given it away too heavily at the beginning. But very common in our regional area and the time of year. So atypical presentations of a common illness, more common than super esoteric things. One of the differential that the neuroradiologist mentioned when they read the scan was like something called Tolosa Hunt syndrome. There's this inflammatory syndrome, kind of like akin to sarcoidosis in some way, but more localized involvement. And it can involve the cranial, it can involve the cavernous sinus and the orbits. But one thing that didn't fit with that, that's usually more of a painful ophthalmoplegia, and his was painless. So he's like, hey, he doesn't really have the pain, but nor does he have a known tick bite. He has doesn't have rash. So that was kind of the where the thought process was at the time, but kind of came together nicely at the end.
Thank you so much, John. Thanks, Noah, for taking notes and scribing. And Ibrahim, if you want to just highlight a couple of the learning points you thought were most valuable, and same in the chat. I'll just ask everybody to maybe just think of like one key takeaway they found helpful from this case, and share with everybody in the chat, and we'll close after that.
So thank you, Dr. Block, for this amazing case, and thank you to Steph Zaven for the wonderful discussion. I know that it was a long case, so I'll try as much as possible to actually summarize the amazing teaching pearls that were shared with us. And so this case had started with the double vision. And so if a patient comes in and they're complaining of double vision, typically you want to think of extraocular muscle malalignment. And your next question should be whether this is primarily neurologic in origin versus ophthalmological in origin, because then you will get to actually page either of the two teams, and the differential would actually highly be different if it was neurologic in origin versus ophthalmological. And then we heard that this patient also had a cranial nerve 7 palsy. And so if a patient comes in with a facial nerve palsy, your next step should be to determine whether or not this is an upper motor neuron versus a lower motor neuron disease. And typically after you actually end up with localizing it, you want to also imagine the course of the nerve as it goes from the brainstem all the way to the functional organ itself. And once you imagine that, you should typically assess other symptoms that may help you in understanding whether it's primarily in the nerve or it's in the neuromuscular junction. And the differential for this case it was very wide, and it involved sinus thrombosis. It involved a viral infection, especially putting in fact that a viral infection could have masked an underlying autoimmune disease, such as Guillain-Barré syndrome or one of its subtypes, including Miller-Fisher syndrome. And then there's ischemic nerve infarction, but this was lowest on our differential list, mainly because it manifests with a single nerve involvement. And because this patient had a multiple nerve involvement, we started thinking away from it. And finally, you also have to think about the infectious etiologies, including Lyme disease, which this patient ended up actually having. And for the hyponatremia, remember to always correlate clinically. So because this patient did not have the classical symptoms of hyponatremia, including the nausea, the vomiting, and the confusion, you need to think about other diagnoses in this case, and not that they are having their symptoms because of their hyponatremia. And finally, you also, when you consider Lyme disease, it's also important to think that prior to actually confirming your Lyme diagnosis, it might be a good step to actually give the patient some doxycycline, mainly because it's just an antibiotic, and the treatment benefit outweighs the risk significantly. And if you're still thinking about GBS, just like in our case, you can also consider giving IVIG.
That was awesome, Ibrahim. Thanks again, everybody. Hope y'all have a great day.
Bye. Thanks again, John. Awesome case. See ya.
Yeah. Bye. Thanks for having me.